So hello and welcome to this launch event for Bone and Joint Week 2021. I'm Sue Brown and I'm the Chief Executive of ARMA, the Arthritis and Musculoskeletal Alliance. And I would just now like to formally declare Bone and Joint Week open. Thank you all. So ARMA, the Arthritis and Musculoskeletal Alliance, for anyone who's not come across us, we bring together patient and professional organisations to influence policy and practice to improve musculoskeletal health and MSK health services. If you've not seen us before, please do visit our website, arma.uk.net, for information on our resources, to sign up to our e-newsletter, to find recordings of our webinars, and to find details of our virtual conference, which is taking place on the 6th of December. So today is the start of Bone and Joint Week, which is an international awareness week to highlight and celebrate the central importance of musculoskeletal health. I don't need to tell anyone here why MSK health is so vital. Our musculoskeletal health enables us to move, to work, to live independently, and it is the leading cause of years lived with disability, both worldwide and in the UK. So this is a really, really serious issue and extremely important. Everyone will also know the toll that the pandemic has taken on people's musculoskeletal health, with people not able to access the services they used to access, with people suddenly moving to home working in situations which were less than ideal often. And we know that many people have been less active since the start of the pandemic. So now more than ever, musculoskeletal health and musculoskeletal health services are absolutely vital. The other thing that's happened in the last year or so, which we're delighted about, is that the profile of MSK health has really risen up the agenda, particularly up the agenda of the NHS. And that's absolutely fantastic to see. So Bone and Joint Week is an international week celebrating MSK health. But at this event today, we're going to focus very much on the UK. We're going to be looking at national, regional, and local action to improve MSK health. So I'm going to introduce 4 speakers, all of whom have contributed to that rise in profile for MSK health that I talked about, and all of whom are contributing to improvements in MSK health and services at one or more of those levels. I'm going to start by introducing Andrew Bennett, who is the National Clinical Director for MSK from NHS England and Improvement. And Andrew's going to be talking about what can help MSK health nationally. Over to you, Andrew.
Thanks, Sue. I will just attempt to share my screen and the slides. So just bear with, I'm one of those Teams people. Can we see those okay?
Yep, that's fine.
Yeah, okay. So yeah, thank you for the introduction, and really thanks for the opportunity to come and briefly speak and engage in this roundtable to kickstart.
Andy, you might just want to go into slideshow mode rather than.
That's a good start, eh? Just bear with me a
share
second.
your screen, but.
Yeah, sure.
That's it.
I think we've got a head around it by now, eh? How's that?
Perfect.
Perfect. I will start again. Look, thanks for the invite to come and speak at this roundtable discussion and launch of the Bone and Joint Week. And thanks to ARMA for that. And also, I think thanks to Sue and ARMA for tireless work promoting MSK in the long term, but also within the context of the pandemic, which has been just incredible. So I'm going to give a very brief overview about what can help MSK health nationally more than ever. And I'm going to relate that to our current work in NHS England and Improvement. Now, of course, at the moment, we have a really complex challenge facing us. We've got fundamentally, first and foremost, the need to restore MSK services as we move into this more endemic phase of the pandemic. And we want to do that through the lens of improvement. We don't want to go back to where we were before the pandemic, when we knew there was variance in access, outcomes, and experience. We want to make best use of some of the beneficial changes that have been rapidly initiated in the pandemic to restore to a new normal. Now, of course, we've got to do that whilst responding to the challenges of winter pressures and the ongoing challenges of COVID, to support those waiting for procedures which have been paused in the context of the last 18 months, and also to support vaccination, where there is a big focus related to MSK in the rheumatology space and supporting those patients who are immunosuppressed. And we need to do this whilst addressing known health inequalities. So it's a really complex challenge. Oh, my slide's not sharing. There we go. And to help us deal with this challenge, we've got the Best MSK Health Programme, which I've talked about widely, but essentially has come out of the National Improvement Programme and the 2021-22 operational priorities for the NHS as a vehicle to help us improve whole system productivity and performance, very much in the context of the restoration, but through the lens of improvement. And we want to do that to help achieve our vision of enabling best lifelong MSK health for all. And this programme is very much taking forward the ethos of co-production and collaboration and integration that we've developed over the last 18 months, working closely with a number of other programmes in NHS-EI, as well as arm-length bodies, and aligned with the ambitions of the NHS long-term plan and the integrated care system planning structure to really drive forward our ambition to reduce variation in access, outcomes and experience for those with MSK conditions. And our objectives broadly relate to minimising risk, controlling demand and maximising capacity to enable productivity in a very challenged system. But of course, we want to also enable the best performance and deliver the best quality care, which is a safe, effective and efficient and associated with high patient satisfaction. And we want to do that right across the entire framework for MSK delivery, from primary community care to secondary care, working with the independent sector and optimising the balance between urgent and emergency delivery and protecting elective capacity. And to do that, we also want to make best use of digital resources, many of which that we have brought in the context of the pandemic, to try and support our delivery and our ambitions around productivity. And of course, this is very much aligned, and our ambitions in the programme are very much aligned with the aims and ambitions of the integrated care systems which are emerging right across the country. We want to take a population-based preventative approach to MSK delivery, and that requires integration between the physical health sector, mental health sector, social services and the third sector. It requires integration across specialities, orthopaedics, spine, rheum, orthopaedics, osteoporosis, falls and fragility fractures. And within the ICS, it requires integration across the MSK system between PCNs, place-based providers and secondary care providers. And our ambition is to take the overarching beneficial change of co-production and collaboration and integration that we've developed as an MSK family during the pandemic to enable local leads who have the best understanding of population cultures and the best understanding of local resources to deliver not only restoration and improvement to enable equitable access to best outcomes and best experience. And so that comes back to the question, what can help MSK health nationally more than ever now? And for me, it's about enabling local leaders. We have lots of local leaders at PCN level, place level, within providers and ICS level, right across the country, who are really motivated to build back new MSK provision and deal with the long-standing challenges that we knew we had pre-pandemic. And so who can help MSK nationally more than ever is that local leadership. And what we need to do nationally is be able to enable local leaders to co-produce the restoration and improvement of MSK services and help us best deal with the challenges ahead, but also help us utilise the opportunity we have to move to a new normal. And just a few plugs before I finish. We've obviously developed an Msk Futures Resource to help support local leads in MSK which has resources and pathways developed by our work streams right across the multiple facets of MSK. And also we have a hashtag linked with our Best MSK programme, and please feel free to use that to help discussions around the Bone and Joint Week. And we are always open to feedback as a programme, whether that's with regard to the content on our Futures site, or with regard to anything else that you've been involved with or read. And so attached is our email address. Please feel free to contact us, because the ambition is shared, and the only way we're going to really make the most of the opportunity in a very challenging context is to do this collaboratively. Thank you.
Thanks very much, Andy, for that introduction at the national level. And you mentioned the vital importance of local leaders. We will be hearing from one of those local leaders very shortly. But before that, I'm going to introduce Liz Lingard. Liz is a public health consultant and a physiotherapist, and she works in a regional team, northeastern Yorkshire, from NHS England and Improvement. And she's going to be talking about the regional approach with a particular focus on addressing MSK health inequalities. Over to you, Liz.
Thanks very much, Sue, for the introduction. Can I have the next slide, please, Nita? And as Andy mentioned, when we're looking at MSK health, it's really important that we take a life course and a care pathway approach. And we're really keen that if we're addressing MSK health inequalities, that we are doing this right along the pathway, and we're doing it upstream with what we do with children and young people to make sure they have the best start in life, the healthiest start. We reduce all those risk factors that we know can increase your risk of developing MSK conditions, but we're not just waiting till they occur sort of in working age and older age adults as well. It's fair to say, as we're going into restoration, there is quite a disproportionate focus on the elective care restoration and what we're doing around the waiting list. But again, we're really keen that when we're looking at the care pathway for MSK health inequalities, that we look from prevention all the way through to highly specialised care. When we've cut the data by deprivation to look at what's happening in an A&E department, we know that there's lots of people that are coming there with back pain, so they're using that to access care for back pain rather than going to primary care or to community services. And a lot of that can be underpinned by the fact that they don't understand that they need to register with a GP in the first place, so they don't have access to all those other resources in terms of diagnostics and moving through outpatients clinics and getting onto waiting lists to get onto the elective care pathways. So we just look at the next slide. We look at who is at most risk of facing health inequalities. A lot of people sort of recognize the protected characteristics, but what COVID's really shone a light on as well is the impact of social deprivation and rurality during this time. And we know that people who live in more deprived communities or more remote communities are often in poorer housing stock. They often live in overcrowded housing as well, and they often have lower incomes or access to employment opportunities. So we're really keen that we recognise these factors and how they intersect with the protected characteristics, but also the wider health inclusion groups of people who face health inequalities. And none of these happen in isolation, but where they all come together, the impact on that person's health is massive. You can see when we're looking about people who are facing health inequalities at the top of the health inclusion list, we've got clinically extremely vulnerable and people with long-term health conditions. So we know that many of people in our community of MSK conditions who have rheumatological conditions and were deemed clinically extremely vulnerable because of their suppressed immune system and their access to healthcare and how they've actually gone about living their normal lives and being able to self-manage has really been compromised during COVID as well. So if we just go to the next slide, Andy speaks about, the digital inclusion and all the digital tools that are coming out, and being in part of NHS England and Improvement. When I hear digital by default, I just think exclusive by design. We know that 60% of the population nationally struggle with health literacy and understanding health information that's given to them, and that is higher in the Northeast as well. You can even go down to postcode level data to see what the health literacy levels are for each of your communities. So we know our average reading age in the Northeast is 9 years old. So a lot of people really struggle with health information, especially where it includes numbers. And then when they're trying to access resources using digital tools, Not everybody has the access to it. Not everybody can afford to download calls and classes and other resources and apps and things. So there's an affordability, and we know in our rural communities as well, there's a connectivity issue there as well. So if we just go to the next slide, what we're trying to do when we're developing our MSK services is to develop them equitably so that we recognize who's at most risk of health inequalities by considering that list I showed you, also recognizing those things don't happen in isolation, and where they intersect, we have real challenges for those populations. So we're adopting a population health management approach to segmenting the data, particularly by deprivation and ethnicity, but also by gender and other factors if the coding's there and has good quality coding. But definitely when we segment it by deprivation, we know that we have very high levels of activity in A&E and in primary care for our most deprived communities. But once we get through to outpatients and elective care, that difference goes. And there shouldn't be no difference. We should have high levels of activity within outpatients and elective care pathways as well, if people do have equitable access. So something happens along that pathway to limit the access for our most deprived communities. So going forward, we're co-producing interventions. We're working really closely with our communities in the voluntary sector who have really trusted relationships with those communities. And we're making sure that anything that we design is accessible, affordable, and acceptable to those communities. So a real shout out that it should be Go, Co, Pro, and Loco, as well as Andy said, working with local leaders. And that we recognize as we build back better, it's not about equal. We need to recognize that people come with different needs, and we have to have tailored approaches. So yes, it needs to be a universal offer, but it needs to be proportionate to the needs of that population. And to take the public with us, we need to make sure that we do a comms campaign that goes alongside this so people understand what we're trying to do when we're trying to level up, how they access services that are most appropriate for them, but also why we need to target services to those who are in more deprived or more challenged circumstances. And we know we don't have to do it alone. We've got the regional sort of NHSEI team. We've got our public health colleagues in the Office for Health Improvement and Disparities and in the local authorities, the clinical networks, our wide sort of ranging voluntary sector organisations, and the communities themselves that help us design it, not just as a clinical program in isolation, but alongside our digital teams who are doing digital inclusion, personalised care, and the whole range of programs that are happening, so that it's very joined up for the public as well. So now more than ever, we need to listen, learn, and level up. And if we just go to the last slide, it's just to say, as a region, we're really encouraging individuals and teams to recognise what it means to address health inequalities, who's most at risk, what they can do, sharing experiences, understanding the lived experience of our communities, and building on that. So we can't turn away now, we can't look away, we can't stop listening. It's time for us to act. So we're really keen to share everything that's happening. I'm working closely with Andy and Adana, who's his great deputy within Best MSK, to think about how we share best practice across the system. So that's our regional email. But if you're from other regions and you want to share, please go back to Andy's email as well to share these great examples of work of where this is working. So thanks very much, Sue.
Thanks very much, Liz. That was fantastic. And health inequalities, I think, is something that everyone is becoming more aware of at the moment. There are some massive issues in MSK, and it is a priority for ARMA's work. We had a couple of weeks ago a roundtable on the subject, which Liz was part of. So look out in the next few weeks for the report of that, which will be the start of us looking at what we can all do to try and tackle those health inequalities in MSK. But now we are going to move on to this really vital level, which is the local leadership of MSK improvement. And I'd like to introduce Sarah Morton, who is Head of Therapies at Gloucestershire Health and Care NHS Trust and is the Chief AHP for Gloucestershire ICS, talking about what can help MSK Health locally. Over to you, Sarah.
Thank you very much, Sue, and thank you for inviting me to talk today about the response that we have locally within Gloucestershire, One Gloucestershire Integrated Care System, to the challenges that you've all described. what I wanted to do was talk really just to one slide, which is about Gloucestershire's very established approach to clinical programmes. So if we could, thank you, just move on to this slide. Our musculoskeletal programme within Gloucestershire is very established, and it's been recognised locally and nationally as an exemplar. And we very much collaborate. Collaboration is key with key stakeholders from across the whole system, from primary, community and secondary care, and clearly people with lived experience. Our MSK clinical programme has evolved over the years, dependent and according to the dynamic drivers that we've had. So we're very cognizant of the national agenda. So whether that's been the 5-year forward, the long-term plan, additional role reimbursement, the COVID emergency and recovery responses, the digital opportunities that's created for us, or indeed the workforce challenges that we've all got. So our local approach, I think, is best summarised on this slide. We currently are working through 3 work streams, 3 priority areas, and this has been collaboratively agreed within our clinical programme board. So the first work stream that we've got has very much a clear focus on ensuring people have information on our MSK services and pathways, and that people have a say in those pathway changes. It's also on supporting and enabling people to live well with long-term musculoskeletal conditions, and that clearly includes prevention and self-care. And our representation on workstream 1 includes our first contact practitioners, who have an absolutely key role in this agenda, GPs, our social prescriber link workers, Active Gloucestershire, so our third sector colleagues, the comms team, our communication team, and commissioners. So all very much working collaboratively. And some of those objectives that we've got within that work stream are to increase the number of people who are aware of how to self-manage within our local populations, looking at primary care landing pages to support people with consistent information across our system, across our networks and across our individual GP practices. Exploring things like the Get You Better app and the opportunities that creates for people locally. Training for social prescribers and care navigators. And looking at trying to increase the offers that we already have in place locally. So Key Active, It's Your Move and Artlift. So very much looking at that wider system engagement as part of a collaborative response. The second work stream that we've got is very much looking at the workforce. It's looking at strategic workforce leadership role that we've got in place at the moment. So we do have an AHP strategic lead role, which is a day a week we secured with Health Education England monies. And the purpose of that investment was really to ensure that we were looking at our strategic workforce needs, not only in line with the Health Education England roadmaps for first contact practitioners, but a wider career pathway development that would support our musculoskeletal clinicians, either at first contact and through our core services or our advanced practitioner services interface. And we very much work collaboratively between our acute trust and our community services provider organisations to make sure that those strategic lead roles are really helping to support and drive our ambitions for the future, so that we have sustainable workforce models to prepare us going ahead. And those roles link very much in with my chief AHP role in the ICS. They also link in with the MSK clinical programme, so very much tied in, obviously, through the workstream 2, and our primary care training hub leads and colleagues. The third work stream that we've got is very much looking at secondary care and our specialist services in secondary care. And the post-COVID impact on capacity and ensuring that we do use our specialist services absolutely appropriately, so following on the GIRFT principles, and that we do make sure that we are ensuring people who go into secondary care do need that intervention. And that third work stream covers rheumatology, pain, orthotics, and our trauma and orthopedic colleagues. But the third work stream is very much interdependent on work stream 2 and work stream 1. And I think the key really is to making sure that through the clinical program approach, we are making sure that we collaborate across the pathways and across the system and across the work streams that we have at the moment. So now more than ever, with the challenges that we have in the short to medium term on capacity through the system, it's key and imperative that we work not only as clinicians and colleagues through the system, but with our third sector and voluntary sector to make sure that we really pull together the resources and collaborate to maximise our efficiency. Thank you, Sue.
Thank you very much for that. Thank you particularly for your final point, because ARMA's membership includes a lot of patient organisations, and we are incredibly keen to promote the contribution that they can make to people's ability to self-manage long-term conditions. So really pleased to hear that you mentioning them as key players in the local picture. So our final presentation before we move on to some opportunity for discussion and questions, I'd like to introduce Jane Taylor, who has an awful lot of hats, but the few that I would mention here are: she's been living with MSK conditions for 35 years. She's chair of Versus Arthritis's Patient Insight Partner Group for MSK. She's an advocate for co-production and for the patient voice, particularly in research. And also she is a trustee of ARMA, and it's great to have her on our board. So Jane, if you'd like to talk a bit about what can help from the perspective of people with MSK conditions.
Okay, thanks, Sue, and thanks for the invitation. It's really nice to have a chance to talk here from the patient perspective and to fill in some of the detail in the kind of things that the other speakers have mentioned. So can I have the next slide, Nita, please? So this is one thing that we can be grateful for, I suppose. We're not centipedes. We're sitting here, those of us with joint pain, but at least we don't have 100 legs. But what I want to start with is the opposite of what the centipede is saying. He's saying, don't talk to me about joint pain. And I think we need to talk about joint pain. I think joint pain and pain in general has been very much a poor relation in services to other kinds of treatment. And we know that pain generally has a huge impact on the quality of our lives. We know that chronic pain affects our family, it affects our relationships, mobility, work, mood. There is really no area of life that chronic pain doesn't touch. And Liz talked earlier about inequalities, and we know that MSK conditions don't affect everyone equally. We also know that chronic pain doesn't affect everyone equally. So just to give you one statistic, we know that women who are living in the most deprived parts of the UK report, well, 45% of women report chronic pain for living in those areas. Whereas if we look at men in the least deprived parts of the UK, the percentage is only 27%. Still a high and worrying percentage, but not the 45% that we have with women in the most deprived areas. So I think that's the first thing I want to say at this time, where we need to talk about pain. We need to stop apologizing for it, to stop internalizing this idea that there's something wrong with us if we talk about chronic pain. There isn't, and we need to address that. And actually, patients talking about pain has begun to have a difference. We've now shifted the dial in research so that there are some really big initiatives to try and research and understand MSK pain. And hopefully that will then transfer into services when the fruits of that research come out. So let's all talk about pain, and let's keep talking about it because it is really crucial. Can I have the next slide, please, Nita? So if I had a wish list, this is what it would look like for me, for good MSK care, not just for me, but for all the people and all the patients that I talk to. So first of all, it would be integrated. We've heard a lot from various bodies about integrated care. But really, if you're going to have genuinely integrated care, it has to be co-produced with patients, because many of the systems that we have at the moment are silo-based systems. Many people like myself don't just have one MSK disease, but live with a number. And many people also, of course, live with other conditions. So we need to have genuine integration. Practical example, I live 11 miles away from the hospital where most of my secondary care is managed, and yet my GP practice and my hospital joined digitally. So I am the integrator. I am the person who has to connect up absolutely everything: blood tests, physio, podiatry, secondary care, conversations with consultants, drug delivery companies. And let me tell you, it's exhausting. It's exhausting because I don't have the power to do that. I don't have access to the kind of systems I would have if I was a professional in those systems. I'm also a carer, so if you double that, I have to do it for someone else that I live with as well. Then an awful lot of my time is taken up trying to connect up systems which aren't speaking to each other. So integration, really, really important. Accessibility, also really important. And that's not just physical. Physical accessibility is important. I was shielding during the pandemic. Well, I live in Manchester, so in fact, we shielded for almost a year. Manchester never really came out of shielding. But I had to end up going to Salford, 11 miles away, by public transport. I don't drive, in order to have blood tests, because it wasn't possible for my GP 10 minutes walk away to be able to do them. So we need to make services physically accessible, but we also need to make them digitally accessible. I know that Liz mentioned that many people are struggling with this kind of digital by default, where they're not being given a choice. It's not working. It's not working for many people. It has to be a choice. Accessibility is also psychological. It's also cultural. We need to look at how easy is it for people to approach these services? How easy is it for people to get there? Again, in the middle there, co-produced with patients. If you get patients involved in designing these services, then you'll start to understand what the barriers are. The next one, flexible and inclusive, really important. I'm someone who isn't just a patient. As Sue said, I do lots of other things. I need to work part-time. I am a carer. I can't always just sit waiting for my one call back from a GP, from an unknown number, that if I miss on that day, I'll have to go back into the system again and be number 46 in the queue at 8 a.m. the next morning. We have to recognize that people are not just patients. We have to design systems that are flexible, that recognize that people have other roles, and we have to make them inclusive. I was quite horrified to realize that everybody else almost who is talking here is a physio or has a physio background. As someone who never exercises and who's failed every physio initiative that I've been offered, I have been stuck at home for almost a year, and I am desperate to exercise, but I can't get access to it very easily. And you have to start with where the patient is. You have to recognize that all these barriers are there for people. And rather than starting with the one size fits all, start with where they are now and work from that. Recognizing connections between physical and mental health. We know that the mental health has taken a huge toll on, the pandemic, has taken a huge toll on people's mental health. People who have been living with long-term conditions and in chronic pain have been very badly affected by the pandemic. we need to try and recognise that it's not inevitable that having a chronic MSK condition means you have to live with a certain level of poor mental health. We do know that 4 out of 10 people with MSK conditions will suffer from depression. So we need to put support in early. We need to ensure that support is there so that by the time someone is really struggling, it's not too late. And finally, I'd like to say we need a strength-based system. So often we see patients in quite a negative light. It's what they can't do. We have a benefit system that also reinforces that. You can't work unless you can do X amount of hours. Any activity that isn't economic is not really recognized as valid. I have friends who've had their PIC taken away because they've been doing voluntary activities. We have to recognize, that people living with MS conditions have other strengths, and we need to work with other systems like the benefit system to try and ensure that they can do other roles, because of that also taps into this issue with mental health and poor mental health continuing. Above all, we need to co-produce all these things with patients and with carers, because then and only then will we understand what's important to people and what are the barriers for ensuring that services can be integrated, personalized, accessible. This should be standard practice. It shouldn't be, a wonderful example. And I feel quite optimistic about that. Although we're coming out of a very difficult time, the Best MSK Practice Initiative, that was co-designed with patients. And I think we have a chance to recognize that and to get it right now, if we can involve patients in every aspect. So I started by talking about the importance of talking to patients and talking about pain. I'm going to finish with the importance of listening, and listening at every stage to what patients want. Because often healthcare professionals are surprised that the outcomes that they think are important to patients are not important to patients. It's often quite different, and it's different for people at different times in their lives. And I don't think in 35 years, I probably can count on one hand the number of times that someone has said to me in a consultation, what's really important to you? What can we do for you today that would really make a difference? What is it that you can't do that you would like to do? I think the only person who's ever said that to me has been an occupational therapist. And I'm really a fan of occupational therapists for that reason. So I'm going to finish with my last slide, if I can ask Nita to shift it. And this is about listening. So listen to what matters with the patient and keep listening. Keep getting feedback. Otherwise, you might end up with patients like this poor horse here, who's probably, had his hip replacement because it's a good winning slogan to get the numbers down. But if it's not what he wanted and the result is not what he wanted, then it's really not a good win. Thanks.
That's brilliant. Thank you very much for that, Jane. And Jane touched on a number of issues that have been priorities for ARMA and continue to be priorities for ARMA. So on our website, you will find information about working in partnership with patients. So stuff about co-production and some top tips for co-production in MSK. And we've also done some work on mental health, and you'll find the report of our mental health roundtable also on our website. So if those are issues that are important to you, then please do check out those resources as well. We now have about half an hour where we can engage in some discussion, take some questions, those sorts of things. So please do put your hand up if you would like to contribute to the discussion or ask a question of one of our speakers. We take questions or comments. While you're having a think about that, we also have a Mentormeter question. So Nita has just popped in the chat a link to that. So you should be able to click on that link and you will go through to Mentormeter, where you will be asked the question, what 3 things need to happen to improve MSK health? So if people, while they're thinking about their questions, want to just click on that and put their thoughts in. Sorry, we're asking you to multitask here. And then if anyone has a question or wants to contribute, then please do pop your hand up. You'll find that in the reactions, on the reactions button. Yeah, we'll just give you a second to do the Mentormeter, and Claire Jacqueline would like to come in and make a point. So Claire, would you like to come in?
Hi, I think that might be me.
Yes, I was going to say it's not me. I didn't put my hand up. It's Elsa masquerading as.
I think Claire sent us the link, which is why I've ended up with her name on my.
Okay, Elsa.
Thank you all very much for some really interesting talks, and it is great to see that MSK is so much more prominent in the political landscape. So thank you all for that. But I suppose what I want to perhaps challenge a little bit is that we see endless mentions of patient-centered care and co-production and the importance of self-management and so on and so on. And we patient organizations work our butts off at producing really good resources for patients, and then find it really quite demotivating, if you like, to find that health professionals are not signposting their patients to us in the way that they could always. And I think in part because health professionals are so solutions driven, you know, they feel it's their responsibility to provide all these things to their patients, but actually we can do a lot of that. We can help health professionals a lot by providing really good resources and being part of the team, you know, being part of that multidisciplinary team and being considered to be part of the team. I don't think we're there yet. And the other thing is that we get no funding. We have to raise every single penny ourselves. We get no funding from government or from NHS England to help us produce these great resources that can be used to help reduce costs in the NHS. And I just wondered if anybody would like to comment on lack of funding from government, lack of resource, and how we get health professionals to stop seeing patient organizations as sort of something out there that they remember sometimes, and see us as much more of a core part of service delivery and supporting patients through providing those great self-management, supported self-management resources.
Well, that's an absolutely brilliant point, which we can tell because it's resulted in a flurry of comment in the chat and a flurry of hands up. And I think Andrew got in first. So Andrew, do you want to start on this one?
Oh, got in first. Okay, so what a really good question. I think at the start of the pandemic, and when I was fortunate to come into this role as NCD, I think one of the challenges we had in MSK is we had lots of brilliant work going on in lots of different places, whether that was in NHSEI, whether that was in the arm's length bodies, whether that was in the sort of professional charitable sector, but it wasn't necessarily joined up. Now, when the pandemic hit, we had the opportunity to join up very, very quickly. And we did that, I think, quite successfully, working with our larger professional bodies and patient organisations, and then also working really closely with Sue in ARMA to fully engage the wide MSK world. And our ambition there was around the sort of objectives of supporting surge capacity, maintaining urgent emergency pathways, and reducing transmission. We wanted to make sure that the messages coming out, the multiple points for MSK were the same and they were coordinated. And I think we did that pretty well. And it's actually out of that ambition, in part, that we've got the best MSK health programme, because the biggest beneficial change for MSK, aside from trying to ensure co-production is a default, which is easy to say and harder to do, is the integration across the wide MSK family. So the challenge then is to take that forward in the case of the restoration and improvement within the best MSK health programme. And we're trying to do that. So we're working very closely with VA and Sue in ARMA within the work stream. So for example, the rheumatology work stream, our ambition is to ensure that the work produced by that work stream is co-produced by clinical experts, working with our GIRF leads, working with the right professional organisations and the right patient-facing organisations. And that's what we're trying to achieve. Now, that is always a challenge, especially in the complex situation we're in, but that's what we're trying to move towards, because essentially the future of MSK is this collaborative approach. It is about triple integration. It is about the health sector working with the mental health sector, working with social services, and working with the third sector around a shared vision of enabling best MSK health. Because that's the only way, I think, with our growing demand and massive challenges, but also we can be productive, making the best use of our shared expertise. And of course, if we've got a vision to deliver the best MSK health for all, then all need to be involved in it. And that's what we're trying to achieve. We haven't got it right yet. We've tried to do this very quickly in a very challenging context, and that's where feedback is welcomed. But it is very much what we're trying to do.
What about funding?
So I'm going to dodge that. Essentially, I can't really comment on funding from the government or from NHS England for charitable organisations. In terms of MSK, our resource pre-pandemic in NHS England was me and things going on in programmes. It's fantastic that we've now got more resource to enable this programme structure that we want to deliver. And it is a massive step forward. But of course, right across the piece, there are resource challenges. And I would be in trouble if I probably went into greater depth about what funding is available from NHSEI. And of course, I don't work in a government for the government, so I can't really comment on that.
Thank you.
Well dodged, Andy.
Yeah, I tried.
Although I would say any of you on this call who are commissioners, then if you are looking to get significant amounts of support from voluntary sector organisations, just have a think about where you're choosing to spend your funding and what would be the most cost-effective way of doing it. Because I can tell you, small charities are incredibly good at delivering a lot of impact for a very small amount of resource. Not that I'm biased in any way whatsoever. And so Lizzie wanted to come in on this one as well.
Hi, I was just going to sort of give the perspective of a rheumatologist who's desperately trying to get her patients to link in with the invaluable resources that are out there from NRAS. And Elsa, I think we need to be very careful here that I suspect it's not always about departments not signposting patients to fantastic patient organisations like NRAS. It's whether patients then choose to engage with that support and at what stage. We have been, as you know, very, very actively trying to encourage patients to take up the offer of what's available through NRAS. And we struggle. We host monthly Zoom meetings for patients. We've advertised it to in excess of 3,000 patients within our department coming through for monitoring all our biologic patients. And I get between 15 and 20 patients zooming in for a meeting. It's devastating that unfortunately some people don't value the benefits of learning about self-management. And I think we've got a job to do as clinicians to help patients understand. And I think there is an element of concern as to what we mean by self-management. It was really interesting when we put this to our patient support group, that when they hear the term self-management, they think it's the doctors and nurses and rheumatology team leaving them to their own devices. And I think that's something we've got to think about, the terminology, because I think that's quite a common theme that comes out when we speak to patients. That's what they think self-management is about, not empowering with them with the skills to manage their condition in between those appointments and to live with their condition on a daily basis. Yeah. And it's so sad because as a department, we've had MDT clinics where you meet every member of the team, where we've had maybe 3 or 4 patients every couple of months take up that offer. But time and time again, the patients who engage with those initiatives come back and say, why doesn't everybody come and do this? Yeah. And that's what's so upsetting for us. So don't take it hard that you're struggling, because we struggle to get patients to engage with that aspect of their care. I think we've got a fantastic offer to sell through NRAS. And I know we've had discussions about how we get the support to NRAS to deliver those initiatives and scale them up, because there is investment needed and it does take an amount of money. But I think it's very difficult. And the challenge is you supply that information to patients with rheumatoid arthritis, but I have another 50 conditions where patients need that self-management support, if we're going to use that term. So it's how do I have those resources and networks to signpost patients to every single, and that is a bit of a challenge, but we certainly do our bit within our department to signpost people to Lupus UK, to myositis, to the Scleroderma Raynaud Society, to NRAS, to ARMA, to Versus Arthritis. We spend a lot of time promoting. So I think there's something here about helping patients to know what they're missing out on. Yes. And the word self-management, I think it's a put-off, unfortunately, for some.
Maybe we need to collaborate more effectively across the specialties to try and find ways in which we can jointly sell the concept as being something rather different than perhaps, as you say, people are interpreting it as. Yeah. Mm. Thank you.
Thank you very much for that insight, and particularly I think it is really important, the language. I think it's quite hard for clinicians, especially those who've been practicing for a while, to remember what it was like not to know what any of these words meant. And again, this is another role for co-production, of actually checking with the people, with the actual target audience of your resources. Does this language mean what I think it means when I say it, when you hear it, or when you read it? And also, just to mention that week on Friday, we have a webinar about the role of patient organisation, specifically in rheumatology. So anyone here who is interested in or involved in rheumatology at all, in a moment I will pop a link in the chat for anyone who wants to register for that webinar. Anyone watching the recording of this after next Friday, the recording of the webinar will be on our YouTube site, so that will be, you'll be able to access that. So thanks very much for that contribution. And Liz Lingard would like to come in now.
Well, I was going to come back about the funding, the thorny funding issue, but given the conversation's gone this way, I thought I'd come in about this first and then go on to the funding options. But just, I think it is interesting when people talk about lots of resources out there. And, you know, as I said, the health literacy challenge is huge. And although I'm sure that these resources have been co-produced with patients, we don't often ask the patients how much they're able to understand these materials. We don't understand what their health literacy level is, nor do we understand potentially their patient activation measures or how activated they are to adopt that. So there's something about that step before just signposting, having someone, if it's not the frontline clinician, maybe somebody from the personalised care teams who are trained in having those conversations to help see where patients are in terms of that journey, in terms of being activated to step up and access those resources and how they help them to get there. Now, we had a fantastic example of an MSK Connect service in West Yorkshire and Harrogate when we had a regional webinar, and they spoke about when people were referred in and they didn't attend, they saw that as an option to keep going back out to them to say, how can we help you, come and do it? How can we engage with you more? Now, often 3 DNAs and you're out has been a bit of a rule in the NHS, but they saw that as a challenge. And they actually said with some people, they just were saying, I've tried everything. I'm tired. I'm not going to, you know, I don't want to engage. And they actually, one man eventually said, oh, all right, if it means this much to you, if you keep ringing me, I'll come and join in. And they got him in and they did it. It was a fantastic program because they were very flexible about the time of the offer and how they were doing it. But as Sue said, it was something that was delivered through the voluntary sector. So they are more light of foot and flexible and able to mold to the communities that they serve. And it's a fantastic service. It's evaluated well, but they still have those issues about not having that guaranteed funding year on year. Now, I think the gift of the funding sits more locally now. It's, you know, all of that with the ICSs becoming statutory bodies from April next year, making sure that you have solid funding going forward. It has to be on the ICS radar, and they have to be seeing the value in investing in these schemes. So in Leicester, and Rutland, for supporting primary care, they've actually done it as an investment scheme, and they've tailored how much funding each primary care network got based on deprivation, clinical need, and communication issues. So people who, GP practices that had high levels of people with sight and hearing loss and learning disabilities got a greater share, so that they could put in that personalised care support and more tailored support to support people to become more activated, to take up the sort of the self-management offers and all the other support that's there. Now, it wasn't just for MSK, but that is the way to do it. And it was top slicing the secondary care money, because that's where the bulk of the funding goes into secondary care, even though the majority of consultations and care happens in primary care and the community. So I think in terms of the funding, it's not going to be something that comes down through the national NHS England routes. It's going to be something that has to come through the integrated care systems, because that's the future and that's the way forward. So I'll just pause there, so if you've got any follow-up questions.
Brilliant, thanks very much for that. And Louise is wanting to come in, but just before we ask Louise to speak, I think we're going to share the results of the Mentormeter about what are the things that people on this call think are important. So here we go. What have we got? Integration is the largest one, engagement, education, and then quite a number of other things suggested. So yeah, we've got quite a broad range of suggestions there, but education, integration, and engagement are clearly the top three. So that's brilliant. Thank you very much. So now, Louise, if you want to come in.
Afternoon, everyone. So I just wonder if we could take a bit of a leaf out of the book of post-COVID services, because I've spent the morning in our Shropshire Community Trust post-COVID clinic, and we've had quite a lot of funding from NHS England to set up an MDT. There's a national app called Your COVID Recovery, which has got lots of advice and rehab materials. And where there's a will, there's a way. So NHS England have thought it's important to put money into this scheme. We're working together with rehab teams, pulmonary rehab, physical rehab, mental health services, a bit like a pain service, really. But I just feel maybe we need to do something like that and change our tack.
Thanks, really good comment. And lots of people, I think, in all sorts of ways are looking to the experience of COVID recovery to see what lessons can be learned. Certainly, what can we learn from the COVID vaccination programme around equalities came up at our equalities roundtable as well, which was really interesting. And that has got Andy wanted to come in. So Andy, how would you respond to that?
Yeah, no, I'd agree. There's a lot to learn from that work, and there is an overlap with the drivers, I think. We are trying to take that sort of multidisciplinary approach. Certainly the national team is massively diverse. There are a couple of us physios, because of course I'm a physio by background, and you, National Clinical Advisor in Personalised Care, is a health psychologist, and of course she would be chomping at the bit to talk about the conversation we had before, and she's holding us to account with regard to co-production, personalised care. And we've got surgeons, rheumatologists, nurses. We have got a diverse crew that is driving this work, and we want to translate that down into, as Liz quite rightly said, the new integrated care system structure, which of course is all about integration and about multidisciplinary work And we need to have that approach to integrated MSK services. We said within the presentations that we're moving away from a siloed based structure to MSK to that of integration. And of course, in the Mentormeter feedback, integration was at the heart of what we're saying. And so part of that integration is the multidisciplinary format. And if we look at our high impact strategy, which we shared a few months ago and is accessible on Futures, there is a lot of comments there about how at local level we can make best use of our resources around population needs to integrate. So good examples would be integrating FCP within robust models of delivery. So not FCPs in silos on their own, but working with local primary, community and secondary care services, or the use of MDT meetings to inform spinal decision making. And certainly in my day job, which I try and fit in at the same time, we've developed an integrated spinal MDT with pain management, with the surgical team, and with our advanced practitioners and psychologists, and it works really well. Now, that doesn't mean that model will work everywhere across the country, but we're taking that ethos of integration, the multidisciplinary approach, right across everything we're doing. And we have to, because MSK requires multidisciplinary interventions because our conditions are associated with pain, and pain is driven by multiple factors across the biopsychosocial spectrum. So I think you're very right, Louise. We are trying to take that forward.
That's brilliant. Thank you very much. I'm going to ask Emma, who I don't think has spoken, to come in first, and then we'll come to Lizzie.
Sorry, trouble unmuting myself there. Hello, everyone. Yes, Louise, I think we can take some learning from the COVID recovery services, and I think we need to start to think a little bit more widely that it isn't. We can't have MSK services or services that address issues for those of us who have MSK conditions without actually thinking about the rest of the body as well. So you know, my interest is in Ehlers-Danlos syndrome, connective tissue disorders. They don't only affect the musculoskeletal system. So we have to, for us, that service needs to be addressing pain and fatigue and musculoskeletal issues and gastrointestinal issues and mast cell issues and so in a little bit, I mean, I hope that eventually the long COVID services will grow and expand to be inclusive of conditions like Ehlers-Danlos, because the overlaps are it's going to become impossible to differentiate who's got long COVID and who's got chronic fatigue and pain related to other factors over time. You know, I'm thinking in several years from now, it's going to be impossible to know who was initiated by COVID and who was not. And if we can properly grow those services to have them, I think they have to be at a community level. I don't think they should be in secondary care. I think they need to be right back into the community. But with a focus that isn't open. I know we're here talking about MSK, but we need to just bear in mind that we've got to think of the other body systems as well. And so I think they need a generalist approach, not just. I think we're in danger of moving from the old silos to a new silo where we're thinking about only the MSK system.
Well, that's set a whole load of hands flying up. And I did promise that Lizzie could come in next, but then I think Natalie probably wants to respond to what you said. And Andy wants to come back in again, but let's just see what Lizzie wanted to say, and then we'll follow on from that point you made, Emma.
I was going to, as you probably gathered, sort of mention something else, but I think there's as a rheumatologist dealing with multi-system diseases, We very much value that there's a lot more that we see in rheumatology clinics than just MSK related problems, you know, considering the vast array of diagnoses that we see. But I think this does highlight the important bit about how we try and help avoid the revolving door situation. And I think it links to a conversation around managing expectations. Often, unfortunately, it is this case, and we see this time and time again. You know, I'm not too long in the tooth, but I've been at this job of being a rheumatologist for the last 10 years. And I've certainly seen a lot of patients cycle through different specialties and such. And I think that's where that integration is key. And I think it becomes key even more so when you've got conditions where there's this multi-system symptomology and multi-system involvement, because you find people circling around even more numbers of specialties. But I think linking this in, I think linking back to, there are certain things which are so important across any long-term condition and any painful condition. And I think what I find frustrating as a clinician is why there isn't a, if you like, more generic, you have a long-term condition which results in pain, where you need to help to understand about the benefits of healthy lifestyle, about pacing, about fatigue, about sleep hygiene. And there used to be a really good program called the Expert Patient Program, which was fantastic because it would link patients in. And so many people have lots to learn about different conditions from each other and living with a long-term condition. And that was obviously decommissioned, but that was a centrally funded expert patient program. And we had a number of patients who became expert patients, educating other patients. And it was a real lived experience platform for patients to speak to each other and to learn and cross-pollinate across conditions. And I suppose I struggle with why it was decommissioned. And now we've got these sort of silos of, well, if you've got rheumatoid arthritis, you should try and do this self-management. If you've got ankylosing spondylitis, it should be this. If you've got lupus, then we'll send you off in this direction. And I think we have a lot more to offer, and that's just in rheumatology, and then open it up to MSK and more sort of chronic pain, EDS, hypermobility and such. We've got a lot to learn from each other. And I think we've got to help patients understand that a lot of those principles are the same across whatever condition you have, which links into where Emma was coming from with her comments.
And the expert patient program does still exist in some areas. It's commissioned locally, but I know at least there are a couple of places in London where expert patient program continues and is actually also providing the service to people with post-COVID syndrome. So Natalie, I'm pretty sure I can guess what you might be going to say, but see if you can prove me wrong.
Well, I'm probably going to be doing two things. So first one, absolutely agree with those people that say that we need a more, and I call it a versatilist workforce across the piece. People that have got breadth and depth across a range of long-term conditions, because that's what we have learned from COVID and long COVID, is that it's multi-system. And like an awful lot, whether it's inflammatory arthritis and other long-term conditions, there's more than one thing going on. And we should be looking and listening to patients about what their symptoms are, and then actually looking at making sure we are advising them as to, what we can do to help them do what they want to do best and live their life to the full. So I couldn't agree more. So quite a few people have recognized it. What we see is that we carry on doing the way things that have always done. And I think we, and I'm talking now as a director at the Chartered Starter Physiotherapy, I think the profession needs to do some looking and listening and learning. And we've got to change the way we've actually delivered services like forever. I don't know why they're still in hospitals. Why aren't they local? We've been talking about it for the last 25, 30 years of my career, and we're still not that much more forward. And it's great to see Sarah today, who I've known over many years, looking at delivering locally. And that's what it's all about. And I offer a point because there's a piece of work we've been engaged with Keele University on developing standards, MSK standards they happen to be, but they're looking at standards for commissioners, for patients, and for our members. And I think this is an opportunity to push within those standards how we need to focus. And I come back to, I think it was Liz Lingard saying, we've got to sort of level up for the most deprived and those with greatest needs. So the health inequality piece has got to be absolutely central to what we need to deliver for local populations. And so we're going to make sure that within those standards, which will go out to everybody, that's what we expect. We need to use those as a way to shift. And I really do mean change practice and to focus on delivering it differently for best effect and greatest impact. Because I think there is, if you look in an awful lot of areas, we and others are delivering some services to the worried well, not for the people with perhaps the greatest need. And Liz actually highlighted, whether it's the most deprived areas or the people who are really hard to get to, who've got the greatest health need, which will impact on the systems, whether it's health and social care, the greatest in terms of outlay. We've got to really focus on those and do whatever that takes to actually improve their health and their management of their long-term condition. So sorry for the rant, but feel very passionately about both those things.
Brilliant, thank you.
And I've got a very bad knee, so I know what it's like to live with pain every day.
And thank you very much. And Andy has his hand up, and in a moment I'm going to give him the last word because we are coming towards the end of this session. Just wanted to say that Natalie did a brilliant presentation about the concept of a versatilist at our conference last year, virtual conference last year. We have a virtual conference coming up this year, and quite a lot of the issues that have come up here today, including the issue about long COVID and what that's going to do to MSK services, are going to be on the agenda. So if you want to carry on some of these discussions, please do consider booking to that conference. And if you do it in the next 10 days, there's even a discount code, which I'm just popping in the chat box. Now we're doing a bone and joint week promotion of our conference, so do consider that. So before I bring Andy in, I think Nita has one more Mentormeter question. This is where we get you to nail your colours to the mast and ask you, what one thing will you do to celebrate Bone and Joint Week and promote the issues that are happening that we've been talking about today? So if you want to click on that, we may run out of time to share the results on this session, but we'll certainly share them on social media. So if people want to go on that, then that's great. But I'm going to ask Andy to come in as a final word with a final word before we close.
Thanks, Sue. And it's kind of a response to Emma's very valid point, and I'll try and link that with a final word. So look, what a great set of presentations, what a really interesting discussion, and a great way for us to sort of open Bone and Joint Week with your fantastic cut of the ribbon, Sue. I think, look, what we're talking about is moving from a reactive biomedical approach to MSK to a population health preventative biopsychosocial approach to MSK. Now, of course, that is a balance. Like we make any move, one of the criticisms of the biopsychosocial model is we throw out the bio. So that's then about getting the right patients in the right place at the right time, which is a combination of the right triage, but also the right supportive self-management. And I very much think that the terminology needs to be right there. That was a really good discussion. And we're doing that on the basis that the majority of our demand is long-term conditions, long-term MSK conditions, that are best managed in primary and community care. And the interesting thing then is to look at the drivers to those. And what are those drivers? Well, broadly speaking, physical activity, mental health, smoking cessation, good sleep, good diet, maintaining health and well-being. And that's when we look at what are the drivers for metabolic disease and for cardiac disease and for respiratory disease. And to some extent for long COVID, we have those shared drivers. So as well as that balance within the MSK speciality that we're talking about, I think there is an opportunity, and Emma, you've hit the nail on its head, for us to step back and stop thinking of ourselves as knees, hips, widespread pain, but start thinking of ourselves as people and thinking about multi-conditions driven by shared drivers. And certainly I think that is one of the big opportunities in the medium to long term for us to take MSK services forward, looking in a different way, working in collaboration with colleagues in other specialities. And we're doing that. Our new lead for personalised care in MSK shares a role with a lead for respiratory and a lead for cardiac. And we, in our Best MSK Health programme, are working very closely with cardiology, ophthalmology and urgent emergency care. And the learning from different specialities is huge, but the ability for us to work with them is also good. And in terms of constrained resources, which we have, surely that's the way forward, because we can be more productive using our resources in a different way. And so I think that comes back to that Mentormeter. What have we all talked about here? Well, it's integration and it's collaboration and co-production. And that really is, I hope, at the heart of a lot of conversation in our Bone and Joint Week. And I encourage everybody to tweet and talk about it and further raise the profile of MSK, which, although it's positive, it's rising, needs to continue. So thank you all. And thank you, Sue.
Brilliant. Thank you very much, Andy. Just to emphasise that point that Andy was making about the fundamental nature of MSK health in relation to other health conditions. Nuzat Ali from Public Health England, as was, has often said there's no health without MSK health. And I think it is difficult to overstate the importance of our MSK health as fundamental bedrock of everything else, including other health conditions. So yes, please do. Nita has put in the chat a link to the resources and the infographics if you want to raise the profile of Bone and Joint Week throughout the next 10 days, because it's actually, I think it's 9 days or 10 days rather than just 7. That's because MSK is so important. So please do support the week. And please do continue to support the rising profile of MSK health at whatever level you're working, national, regional or local. And just thank you very much to everyone for joining, and particularly thank you to Andy, to Liz, to Sarah and to Jane for your presentations that kicked off a really fantastic discussion. Hope to see many of you at future ARMA events. Thank you very much.